I'd like to welcome everyone to today's Health Equity Grand Rounds featuring Dr. Alex Kral. Dr. Kral is with us today. He is a distinguished fellow at the nonprofit RTI International and is an epidemiologist with expertise in community-based research with urban poor populations and drug policy. His policy and evaluation research has included syringe service programs, overdose education and naloxone distribution programs, supervised consumption site programs, and drug decriminalization policy. He is currently the principal investigator and co-investigator on several National Institute on Drug Abuse, Centers for Disease Control and Prevention, and Arnold Ventures supported studies of the relationship between substance use, criminal legal involvement, infectious diseases and overdose, and federal and state drug policies. He has authored or co-authored more than 200 articles in peer-reviewed journals, is regularly interviewed by journalists in print, podcast, and visual media, and provides testimony in local, state, and federal legislatures. I am truly delighted to welcome him today to talk with us and present some of his more recent research. He will be presenting for about 50 minutes today, and then we will drop into Q&A. This is a webinar format, so that means if you have a question, you'll need to use the question and answer format. We'd like to hold most questions until the end, but if you have a point of clarification or something that sort of in the flow, please put it into Q&A. We'll try and catch it and sort of answer it as we fly. And with that, please welcome Dr. Alex Kral. Thank you so much.
Thank you very much, Dr. Haddock. This is great. Great honor to be here today. I'm really excited to get a chance to meet with you all, and I'm excited about the Q&A format after this as well, to get a chance to talk to you all. See if I can put this on. There we go. There we go. Is that showing correctly?
We can see your presenter mode, but
see, that's probably not the way we want to do that, is it? I don't have any notes in my presenter mode, so in some ways it doesn't really matter. How would I get rid of that? Does anyone have a good idea about that?
no, it's actually been a minute. Display settings, probably.
Yeah, well, maybe we'll just go with this. I don't think it matters that much in this way, because I don't think I have any notes. All right, so yes, I've been asked to specifically talk about overdose prevention sites, and to present some of the global and domestic research policy implementation for that. And because this is a minority health disparities grand rounds, I wanted first to just talk a little bit about the issue of health disparities. People who use drugs, there's huge health disparities for these people, and it is really, if we think about it, is one of the few populations for which we make things illegal that they're doing. We, a society, there's a lot of law enforcement to stop them for doing the kinds of things they're doing, and there's a great deal of stigma as well. And so, people who use drugs are highly stigmatized, and like socially acceptable to do so. People can do so at a cocktail party. People can do so on Twitter or on Facebook. People can say derogatory things about people using drugs all day long, and it's perfectly fine. And in fact, not only can people do that, but let's have a bunch of initiatives to figure out ways to put them away in jail and in various different ways. And because of this, we're not surprised that there's a lot of health disparities with this group. And certainly here, last year's paper by Joe Friedman, and al, that, looking at the death rate per 100,000 among people using drugs, we also see huge race and ethnic disparities with respect to that. And in fact, while, all of these death rates have been going up hugely, especially as part of fentanyl entering the drug market in the United States, what we've seen recently is huge increases, especially for non-Hispanic Black. That's the blue lines here, and also for Latinx populations as well. Those have been going up quite a lot, and so they're really traveling together, these disparities in that way. I think just to first give you an example here and take a look here what this whole concept of harm reduction, for those of you who don't know what that is, harm reduction is basically a set of practical strategies and ideas that are aimed at reducing the negative consequences associated with drug use. And it's not sort of saying then, hey, drug use is bad, no one should use drugs, and until you use drugs, we can't even help you. It's actually saying, hey, we're going to start with who you are and what you're doing, and let's see if we can increase or help you or improve your life, and that may include reducing drug use or stopping drug use, but it doesn't have to. And so it's non-judgmental. It's really it's client-directed. It's non-punitive approach, and it's really offering a set of practical strategies and interventions. And if you really look at it over the last really 3-4 decades now, if you're looking at the evolution really of this harm reduction principles, it really started, and I think this is an important point to make, a really important point to make in general, is that every set of services or harm reduction practices or ideas was conceptualized first by people who used drugs themselves. It was implemented by them, usually in hostile and unsanctioned environments. And so this is not a situation whereby, clinicians or folks out there are coming up with these ideas and saying maybe this will work for this population, but rather this is generally people using drugs, taking things into their own hands and saying, this is what we need to do. This is how we're going to keep ourselves as healthy as we possibly can. And so some of the initial strategies then, focused on practical low threshold things like syringe service programs or needle exchange, as you've probably heard them called, which really started in the 80s. First in Europe, actually in response to hepatitis in Holland, but also came to the United States in the mid to late 1980s as well. And then it's evolved to other things like drug checking strips, which have been around now for a few years, where basically people who use drugs figured out that you could take like these urine test strips and you can actually just touch them to your dope, and you can see whether a drug is contained in it as well. And then it's evolved to more explicit focus on centering and empowering people who use drugs. And that's been true through naloxone. Looking at that particular thing, that's also was started with people using drugs back in the late or mid to late 1990s by Dan Big at Chicago Recovery Alliance and their folks up there in Chicago, and drug users unions in Europe and even in the 80s and more lately the last decade or so in the United States. There are these unions as well, to overdose prevention sites, which is going to be the topic today, that really started in Europe in the 1980s and have just very recently started in the US. And then you also have now a proliferation of community-based drug testing programs with fancy FTIR machines and mass spec confirmatory tests to get a better sense about what kinds of drugs are contained in the drug solutions. And so that's just kind of a quick background about harm reduction in general. But I wanted to also make a big point here, that the way that any of these, if you talk about any of these interventions that I just talked about, and how they evolved in the United States, in the United States context, and that's really talking again back to the stigma, talking about the law enforcement and the legal issues. Every time with every one of these things, the services, from let's say needle exchange, the environment is, the governmental engagement it is, law enforcement actively prosecuting people. No, we had the needle exchange and we have with other things too. They're actually arresting people who are actually providing this health intervention. And then what we see is with each of these interventions, they move towards some local and then maybe, first local kind of blind eye non-interference stage for each of these things. And so, okay, well, we know they're doing it, we're not gonna intervene, but we don't like it. We're not gonna publicly say something is going on here, but we're no longer gonna actively prosecute the people doing it. And then it leads to local sort of quasi-legal legislation, if you will, and funding of it, whereby maybe a city, a progressive city says, you know what, we're gonna declare a health emergency every 2 weeks that says that we can break the law this way to do this intervention, and that's and so therefore it's legal locally. But again, the state police or feds could still come in and do something about that and still arrest people doing that, and even some local funding then through health departments. Then in sort of evolution of each of these interventions comes some sort of state legislation, and so maybe a state says, you know what, we're going to legislate this as an okay activity to do. In the case of needle exchange, for example, in California, 2000, they made it legal in the state to do that. We've had many other states legalize it since, and then comes some state funding in some places and not others. And I think at this point, for example, with even needle exchanges, which has been around for 40 years, that's been fairly late, and probably really only a handful of states that are even funding this intervention at this point. You're in New Mexico's or North Carolina's, New York's, California, Oregon, Washington, but not that many. And then finally, you sort of reach to federal funding, with some strong restrictions. Like, for example, again, with needle exchange, well, we can fund needle exchange programs, but they can't buy syringes with it, not with federal money, this sort of thing. And so you have these restrictions that come with it. And then unfortunately what happens then, and maybe this should be more of a cyclical thing, because what happens then is local reactionary legislation, defunding, active prosecution, and you sort of end up back to the first part again, where people are like, wait a minute, this is, and the big word in drug policy is this is enabling people to use drugs. And so and then you get back to potentially law enforcement or various ways to hinder these health interventions happening. And so I just want to make the case that there's a lot of stigma and there's a lot of laws involved with doing the health, providing health to a population that's sort of by definition illegal, and that's it's highly stigmatized, and it takes a long time. It takes, this cycle right here for most things takes 15 to 20 years. I mean, the needle exchange started, the first ones really in 86 to 88 or so in the US, and you get to federal funding with some restrictions not until maybe 5 years ago or so. I mean, it takes a long time. And the same is true of naloxone or even we've seen some of that with drug checking and that as well. And of course, with the case today of overdose prevention sites, we're still pretty high up this early on in the stage of this evolution. So let's talk then about overdose prevention sites. There really should be nothing controversial about this. Here are, and I've listed up some of the main things here that sort of you would tell an audience generally what's an overdose prevention site. Well, it's a place where people can use pre-obtained drugs under the supervision of a health professional who is equipped with oxygen and or naloxone. They're also called safe consumption sites, say supervised injection facilities, or even drug consumption rooms. And these can be standalone sites, mobile sites, or part of a larger site that's providing a broader set of services. But really, if you think about it, like, this is just like a direct observation thing, is all that it really is. I mean, you could do this anywhere. You're just making sure that you are watching somebody who is using drugs, and if there needs to be some sort of an intervention, you're ready to do that. That's it. I mean, how many people, for example, are in hospitals today, maybe even in ER rooms or whatnot, because some event happened or something like that, and they're like, well, you know what? Let's keep them a couple more days because we want to make sure in case something happens, and they're just observing them to make sure nothing bad is going to happen. I mean, this happens all the time. Yet when we're talking about drug use, all of a sudden it's stigmatized, it's illegal to do it. There's all these various barriers because of the stigma that's attached to and how we feel about people who are using drugs. And so that's a big piece of it. And so on the one hand, this is a very simple intervention. It is not complicated in many different ways. And yet what I'm going to show you today is, both that, most importantly, we've got, a lot of research that has been put up and that shows that not only are these sites highly effective, but they're also not problematic. And I'm going to talk a bit about that as well. But there's so much controversy about them. They have existed for 35 years. They're currently in over 200 cities and 15 countries. And the vast majority of these countries, drug use is illegal, just like it is in the United States. But yet they have found that this is an important health intervention, and they're going to do it anyway, and they're going to make it legal in all those places to do that. The first government sanctioned site in the United States, and that's a locally government sanctioned site in New York. There's 2 sites there that opened November 30th, 2021. And so we're about 2.5 years in now, on point in New York City. They have a site in Washington Heights, and they have a site in Harlem there. And I'll be showing some of the data about that. But these have existed for a long, long time. And the scope of the peer-reviewed science is incredibly strong. There are over 100 articles published in the peer-reviewed medical and epidemiological literature on OPS. Scientists from many parts of the world have evaluated these. The academic disciplines of the people doing this has been everything from epidemiology and medicine to criminology, law, public health, quantitative, qualitative. There's been a robust and diverse type of evaluation of these over the last few decades. Some study methods have been quantitative, like I said, qualitative. There's been ethnography. There's been cost-benefit analyses. I'll be sharing some of that work, both first globally, and then I'll be going into some of the work that we've done evaluating these sites. And again, these are not just sort of articles and marginalized journals with low impact factors, but we're talking some of the top journals, medical journals that exist around the world. So the global evidence, and really the way that I like to think about this intervention, is really twofold. First, what impact does it have on the people that use the OPS, the overdose prevention site? And then what's the impact on the communities in which they're placed? Both are really, really important. And so in looking at this work, I'm really gonna divide things into both of these ways. So first, then, if we look at the global evidence on the people, and in terms of the impact on the people who use OPS, there's a lot of studies that have been certainly from many years now that show they reduce overdose deaths. They reduce HIV, hepatitis C, and associated risk behaviors. They reduce the frequency of drug use. They improve health, access to health and social services, and they increase access to substance use disorder treatment. These are great places for doing all of these things that really benefit the people who use them. And then what you see is there's been a little less work on this, but there has been a fair bit of work also on the impact on the communities around them. And what we've seen there globally is that it reduces public injection and improper disposal of needles in the streets. And so that's a good thing for the community. They tend to reduce drug-related crime and violence as well. We saw early on in Canada. And then it reduces the demand for ambulance services for opioid-related overdoses, because they're taken care of, the overdoses are taken care of at the site. And so now you don't necessarily need to have 911 come every time for that. So that's the global, that's the sort of an overview of the global. And what I'm going to be talking about is evaluations, you know, and part of all of these, this work here, but once here domestically and in the United States. And so we were first did a fair bit of work from 2014 to 2020 on an unsanctioned OPS in an unnamed city, and it's unnamed again because of the question of how legal these are, and certainly in the question and answer section, we can certainly talk a bit about some of the interesting things from a research perspective. How do you research something where you really can't in any way sort of call out where it is? And there's a lot of things that we had to do to figure out a way to make sure that we did that research in that way. And then there's the New York site, the sanctioned site that's ongoing now. The main evaluation there is led by Magda Serta at NYU, and I'm a co-investigator on some of that work, and so that's will, you know, has been and will continue to be a rich source for evaluations as well coming up. And then at San Francisco, which is where I live, there was a locally sanctioned overdose prevention site that was open for 46 weeks during 2022, and I had a chance to evaluate that, and our team did as well. And then finally, there's been some cost effectiveness studies that I'll finish just making note of as well about these things, and what the cost effectiveness would be in the United States for cities that are doing this kind of work. So I'm going to go through some of these, what we know from the research findings for each of these, starting with the unsanctioned overdose prevention site in the United States. This opened in 2014, as I mentioned. They had two separate rooms. They had one for injections and one for post-injection. So you see a picture here of these sort of stations where people could then inject themselves. There was the possibility for assisted injections as well. If people wanted to help each other with that, they were allowed to do that. And there was always a trained staff person in each room to make sure that you know, people were using the safe, sterile equipment, that they were disposing needles. They had oximeters to look at their you know, look at their oxygen levels, and they had naloxone on site as well, in case somebody did overdose on a drug solution, including opioids. And then they had a tablet for inputting data, which was our piece, you know, the evaluation piece. And so we had a variety of research methods for this. We had site-specific data then. Every time somebody used it, they logged in a few questions and things like that every time they used the site. And then we had a quantitative cohort study with almost 500 people who inject drugs, who we interviewed at baseline, at 6 months, and at 12 months. Some of those people then did use the OPS, and the majority of people did not use OPS. And so we could compare the people who used OPS to those who didn't use OPS and follow them over time to see what happened. We also had a secondary analysis of crime data from that city that I'll show you some things from. And then all along, we were doing an ethnography and qualitative interviews, and that was led by my colleague Pete Davidson at UCSD, and who was a co-principal investigator on all of this work with me, and there's a large group of people doing this work. So what did we find? We're looking at the site data. There's a paper we published in the New England Journal of Medicine that through those 5-6 years there, the site had 10,000 injections that were conducted at the site by people. Those people experienced 33 opioid-related overdoses, and all 33 were reversed, and no one died at the site, which is what you'd see in pretty much all the research anywhere that has looked at this in that way. I should add that they actually never needed to call 911 for an opioid overdose either, because they were all easily taken care of by the staff there, and so that was another good thing about that. Next, we go on to some of the results from the cohort study that we had there. This first one which showed again, and I'm really focusing on what happens to the people who use these sites first, and then I'll show some of the data related to the neighborhood specifically. around the site. But here, what we found was that the people who used the site, the safe consumption site, as opposed to those who didn't, were less likely to visit emergency departments, had fewer visits there. They were less likely to be hospitalized and have spent 50% fewer nights in the hospital. And so that's a pretty big thing. This is a small intervention, yet it has pretty high numbers here about in terms of health care and healthcare access. We also did a study looking at specifically at people's risk, injection-related risks. While these are not statistically significant, they certainly look in the right direction. There was less receptor syringe sharing. There's less lower rates of injecting in an isolated location, right? That's one of the known points of an OPS is that someone's there with you and they can interact with you and help you in case you overdose. And then also some slightly lower rates of rushed injections that, as well, people rushing the injections that they had. Moving on to this particular evaluation and looking at the community. Well, what does this do to community? Well, we see that there was 58% lower rates of the number of improperly disposed syringes. So that's syringes that people were reporting they were disposing in parks or alleys or on streets, and so there's less needles going out. And then this slide is about the crime data. And so we took all the crime data and we basically took a 500-meter circle around the site, and then we took a similarly sized around two other sites, specifically one being in an adjacent neighborhood that had very similar drug profile, and then another was around a site that was for homeless people, a service organization for homeless people, but they didn't have an overdose prevention site there. And what you're looking at here is over 10 years, then 5 years before the SCS opened, and you see the vertical line here is when the SCS opened. So you have 5 years of data and crime data before it opened in those neighborhoods, and then you have 5 years of data after that. And the green lines is the site. This is where the overdose prevention site is. So compared in the first one here, we're comparing the 500 meters around the site to 500 meters around another site in an adjacent neighborhood. And we actually saw that crime was increasing in that neighborhood until SCS opened, and after that, it actually started to decrease. Whereas with the control site, it was also increasing, but it kept a level at least during that time. And then on the right, you will see that we're comparing the overdose prevention site to a second site. And actually that site, it looked very similar to the overdose prevention site. And so at minimal, certainly the OPS is not increasing crime in the neighborhood, and it's not doing so as compared to other similar sites around the city there. Okay, so a quick summary of the data from the unsanctioned site. It helps people who use them by preventing overdose deaths, by preventing ED use and hospitalization, and also helps the neighborhoods in which they're located by reducing crime, as well as syringes in public settings. So moving on to New York, and really there is a lot more data, but I'm really today going through just the peer-reviewed scientific papers at this point, because I want to keep it focused on science. There is other data. They had an early report even just a couple months after they opened in New York, and what they found was there was 6,000 drug consumptions in events in those two centers. They had 54 overdose interventions with naloxone or oxygen, and again, no fatalities. And I can tell you now, 2.5 years later, these numbers, the number of overdose interventions is well over 1,000, and there's still no deaths that have happened there as well. And so that's an important thing to remember. Similarly, then, looking at what happens in the neighborhoods in which they're placed, and Dr. Chaffin and Del Pozo and the Becerril all basically just published a paper about 6 months ago in JAMA Network Open, where they compared the neighborhoods around the two OPCs in OPSs in New York to neighborhoods that had around syringe service programs. So these are the same kinds of programs. It's just they don't have this overdose prevention site function, but there still were sites where people using or injecting or using drugs are going to, and so that became their comparison sites. And they didn't find any significant changes with relation to violent crimes or property crimes recorded by police, nor 911 calls to the area, or even 311 calls regarding drug use or other unsanitary conditions observed in the vicinity around the OPCs. They also found that there was a significant decline in low-level drug enforcement in the area, 83%. That's quite high, both in terms of the reduction in arrests for drug possession and a reduction in the broader neighborhoods, even if you broaden it out a bit. They also did find significant declines in criminal court summons issued in those areas, both in the immediate vicinity and in the neighborhoods, if we broaden it out around there as well. So next, I'm going to talk about our evaluation in San Francisco, about the site in San Francisco. And this is a site that opened on January 18th, 2022, by the mayor declaring a state of emergency and basically waived bureaucratic and legal hurdles to quickly implement what was called a TLC, or the Tenderloin Center. And within a week or so of it opening, they also had an outdoor overdose prevention site in San Francisco. Given the weather is pretty good all year round, it's possible to do this outdoors. Interesting, very different approach. They didn't sort of just have booths, but they actually have benches for people, and there could be up to 50 people at a time who were using it. Many people now here in the Bay Area and especially on the West Coast have moved from injecting fentanyl to smoking fentanyl. And so a lot of it was people smoking. And again, being outdoors is better for ventilation. You have a natural ventilation for that. It was a temporary declaration. The mayor closed the site 46 weeks later, December 4th. And so what we have is an evaluation that we conducted that included, again, both guest use of the TLC as well as looking at overdose data on site. We had a 6-month-long participant observation, ethnography, and qualitative interviews, and many qualitative interviews there as well. And then we did systematic observations of the streets around the TLC and a comparison neighborhood. And so not looking necessarily at crime, but looking at what happens around the streets, and I'll present you with some of the data from that. So kind of simplifying it here, some of the first level questions here, research questions we had. People weren't sure people would come to such a place. They weren't sure whether people would use the services. Will they feel comfortable spending time there? Will they overdose? Will people die? Is it going to attract people from other neighborhoods to the area, a sort of honeypot effect, as people say? And also wondering, what ways could this model be improved? First looking at the first 3 questions about where they come and what will happen with that. What we see here is in just 46 weeks, 124,000 visits. That is a lot of visits in less than 1 year right there. And then we did have a time, we gave people temporary wrist bracelets with a QR code on it. They QR'd when they went in, they QR coded when they went out, and we could see how much time did they spend there. And they actually spent at this site, they spent a median of 1.7 hours. And for the people who went to the OPS area of the site, their median time spent at the site was 2.8 hours. That's almost 3 hours on median that people go in and do that. And if you really look at it from an intervention of getting people off of the streets and making sure people aren't using publicly in the streets. It represented over 18,000 hours a month of guests who are now not out and about, but are actually at the center and certainly both out of the view of the community, but also being taken care of. That's a lot of hours a month that people are that the people are spending time there. They had a lot of different kinds of services here. This was a a one-stop shop kind of place. There was 12,000 behavioral health interactions. There was over 6,000 appointments and things made in terms of helping people with housing and shelter. There were doctors there for helping them with medical concerns and also with social services. And so there you have one place that can really take care of many, many different things at once. And that includes people using drugs and really for many people, the fact that they could use drugs there was what brought them in. But once they were in, then they also saw the benefits of there being doctors and mental health and being linked into drug treatment and all these various other things as well. And so ethnography really found, and we just published this paper last month or a couple of weeks ago, I think it was, in the International Journal of Drug Policy, on sort of their on qualitatively what happened there and really their philosophy of running this kind of place, which was what they called radical hospitality, which essentially was, look, these people are our guests. We're going to help them with whatever possible way we can, and we're going to center their experience rather than having a bunch of rules and regulations and having things that are imposed upon them. We're going to let them this be their living room essentially, and make it as much as possible their home. For their temporary home for that particular day. That really helped with this one-stop shopping thing too, because people would spend time there, quite a lot of time there. And we found that it created a space for community building. These are people who didn't necessarily have friends or partners out in the community, but they made friends at the site. They made a relationship, lasting relationships at the site, which was really a good piece. And then it really offered safety and respite to guests, and so they could sleep in their chairs. There was actually places they could do that. There was places to just be out of the sort of chaos of what their day-to-day lives might be, and that was really, really important. One thing I kind of like to point out too was, there was a woman who we have a quote from the woman who we interviewed where she said, look, what I like about coming here is I don't have to take care of anybody else. I can just take care of myself. And so when I'm out in the community, I'm always having to worry about do I need to Narcan or use naloxone on somebody? Is something going on? And when I'm here at the site, like the professionals taking care of that, so I don't need to do it. So I can really actually rest and take care of myself. Will they overdose? What will happen if they overdose? Here's a paper we published last fall, and what you see here is there were 333 overdoses at the site during these 46 weeks. These are your weekly counts. Here you see on this graph the number of overdoses by week. 0 people died at the TLC. Now they had a policy here. The city made policy because they were so nervous about the potential of deaths here. But they had a policy that if there was Narcan used or oxygen, and they had oxygen tanks there, they had people who were helping with that particular piece as well. They had dedicated staff to do that. They still wanted 911 to come, and so they had 911 coming each time there was an overdose. But frankly, what happened was a lot of those a lot of those people coming got sort of mad because there was nothing for them to do. And only in a very couple of rare cases did they actually need to actually even do anything at the site during that year. And so this, in some ways, it was a waste of resources to make it a rule that that EMS needed to be called. Will people come from elsewhere? Will there be this sort of honeypot effect, and will there be drug use then brought into the area. Everyone's concerned, hey, you start the site, now everyone's going to come there. Now the whole neighborhood's gone to hell. Sort of I comment, which makes sense. And that was one of the things they were concerned about. We did ask for a couple of months early on where people were coming from each time when they came in. And 94% came from the immediate, the Tenderloin area, which is a very, tight area. And 2% came from the adjacent, the other side of the street, essentially neighborhood as well. There was, there was less than 5% who came any significant distance to the site. And that also does point out that the limitation of one of these sites is that people, you can't sort of put one of these sites in a city and the whole city is going to somehow be taken care of, but rather, people come from fairly close by. If it is convenient and it is non-judgmental and has a good, something like this kind of a radical hospitality kind of, vibe about it, then people will come. Otherwise, they might not come from very far. And so then further on, going to talk about sort of the community around it. We did these systematic observations in the streets. And again, here's a 500-meter radius. This is what we keep using, 500 meters, because the Canadian study did that to begin with a couple of decades ago. So we've used the same as the Vancouver study did back then. So we did a 500-meter radius around the TLC, which is where the overdose prevention site is. And then we had a comparison site that had, it was a resource center for people using drugs, and also a neighborhood with a lot of drug use and open drug use as a comparison 500-meter site. And then we had two research assistants walk each side of all the blocks in that 500-meter radius, record all public drug use, all homeless-related activities and artifacts. And these were actually done 2 years prior even to this being open. So in 2018 and 2019, because they thought that they would be opening them one of these sites a lot earlier than they did. And then once they finally did in 2022, we looked at it then, and these data were collected from July to September for each of these 3 years. So no season issues. Those are, by the way, days. There won't be a drop of rain in San Francisco those 3 or 4 months because we're effectively living when it does right here. So weather is not a concern regarding doing that in that way. So what we're collecting data around. Do you see people smoking drugs, injecting drugs, selling drugs? Do you see discarded needle caps or full syringes? Drug equipment. Is there like visible human excrement? People sleeping on the ground, tenting, shopping trolleys, all kinds of things, property. Those were the kinds of data we were collecting on each block, essentially there. And what you see here is the probability that we found any of those kinds of drug-related issues on a block. And what you see here is in red is the 500 is the neighborhood done at 500 meters around the TLC, which is the overdose prevention site, in 2018, in 2019, and 2022. And what you see is between 2018 and 2019, actually, it was significantly increasing the probability that we found drug-related issues on blocks. But then if you, and we didn't do in 20 or in 21 because of COVID, things look very different in these neighborhoods at that point. And so we didn't bother doing it then. And then you look at just 6 to 9 months after they opened the overdose prevention site, and actually there was significantly less drug-related issues that we saw on the streets. And then if you compare that to what happened in the Mission District, where we did the control site, you see it's completely flat for each of these things. And so that's our comparison neighborhood, and what we found there was a reduction there as well. So quick summary of the findings for the data in San Francisco: 333 overdoses, no deaths, over 18,000 hours spent each month there. The model was appealing to the people who used it, and people will come to these kinds of sites if you make it a place they can come to it. The needs are sizable. In San Francisco, you actually would need a few of these sites, not just in one place, again, because people don't really go very far to go to these sites. There needs to be more ongoing support and daily briefings to improve the staff wellness, because it's tough to bear witness to people in the kinds of conditions they're at. And so that's one of the things that we found could be improved upon. And then again, we did find that public drug use and discarded equipment in the area was basically the same as in 2018, but it was actually lower than it was in 2019. So I think I'm going to move on from the recommendations on that, because I think you probably can see what those would be and look at my time sheet here. What I'm going to finish off with is that there have been some studies around the country in terms of cost effectiveness of overdose prevention sites in the U.S. In San Francisco, we did an analysis. I don't have a date on it here, but I think it was maybe 15 years ago, 10, 15 years ago, that found that every dollar spent on an overdose prevention site would generate $2.33 in savings. And that if you put a single booth, a 13 booth OPS, which is at the time was so saying, okay, if you put what they had in Vancouver into San Francisco, your annual net savings would be $3.5 million per year. These are reductions in HIV, reductions in emergency vehicles needing to come, reductions from people going into drug treatment and various other kinds of things that go into these models. And similar models have since been conducted in Baltimore, where they estimated it would save almost $2 million annually. In Providence, where they compared an overdose prevention site to syringe, to just having a syringe service program, and they found that the incremental savings would be about $1 million there. And in New York, they've also done some analyses. One showing that if they have one OPS, they'd save about $1 million annually, and if there was 4 of them, they'd probably save between $3 and almost $6 million annually. So just a very quick summary here then of the peer-reviewed science. It is rigorous, it is extensive, both globally, and then we've got less here in the U.S., but we've got a handful of evaluations at this point. And I should point out that Providence, Rhode Island is going to be opening a site probably in July, sometime this summer, because they actually had a legislation in Rhode Island 3 years ago now that legalized overdose prevention sites. And so that's the first state that's legalized overdose prevention sites. And it has taken a couple of years to figure out the basics of how to do that and how to implement it and where to implement it and find the right places. But they are going to be starting that in later this summer. I should also mention that the state of Minnesota has also legalized overdose prevention sites last year, and that they're now looking into figuring out how to implement these in Minnesota and where to get the funding from that. And so they're in the midst of doing that there. So there are now 2 states that have legalized these that way. And then, every peer-reviewed study has found positive impact, and both on the people who use these sites and the neighborhoods they're placed. You can't, as a social scientist, I can tell you, you can't really find, especially when it gets to substance use field, you can't really find any other interventions that have been this extensively evaluated in which you don't find any negative findings. That's very rare. Even if you look at most substance use treatment, substance use disorder treatment, you'll find negative ones as well. You're always going to have, and there's obviously a preponderance of positive ones, but there's also negative ones. But here in this, all the evaluations that have been done around the world here, there aren't any negative findings, which I think is an important thing to point out. And I think, specifically what's interesting with that is that going back to the beginning here of when I talked about, it's like, okay, so here we've got a group of people who have a very high likelihood of dying, not just mortality, but also morbidity from a health condition they have, and yet we put all these barriers to actually helping them. And here you have a very, again, simple solution. It's just literally have a space, and it can even be outside, it can be in a van, it can be anywhere. You're just monitoring people and interacting in case you need to, or preventing them from dying in case you do. Very, very simple. Yet because of laws, because of stigma, because of all these various things, they're not being implemented much in the United States. And that's a shame, because we've got a huge problem, especially overdoses in the United States, and it's a growing problem. And there aren't that many interventions that we have that actually that we do know that are socially and community acceptable in this way, that actually help with this particular health problem. And so I also, of course, want to acknowledge, it was just my name at the top there, but that's because I'm giving the presentation today. This is a large team of people who've been involved in all of this work. I mentioned Peter Davidson earlier, who's really been, a co-PI in this, and also Barrett Lambden, who's been a co-PI in the San Francisco study and that work. A lot of people here, from statisticians to research assistants to people like Lynn Wenger, who's been a product director for all these studies. And I want to also mention that this work's been conducted with the support of Arnold Ventures, which is a philanthropy, and also the San Francisco study was funded by the San Francisco Department of Public Health. And I also want to give huge thanks to all the organizations, both at the unnamed site, but also at the TLC, who allowed us entree to conduct our research there and trusted us to be able to do that community-based work. And then included a lot of organizations like Health Right 360, which is a drug treatment organization. It's the largest nonprofit drug treatment organization in California, and they're the ones who actually ran the TLC, which is an interesting thing to have a drug treatment program be the ones that are actually running an overdose prevention center. It shows you the linkage between those is great, and a couple of organizations in Code Tenderloin, as well as Urban Outcomes.